Trauma-informed practice in general is an approach to care and health that acknowledges the trauma that people have faced and how that can impact on their physical, emotional, and social health. In applying that to general practice, we are hoping to adopt specific policy and procedure that will minimize the impact that previous traumas have had on people, stop them from being re-traumatized, and help them to live through the traumas that they've experienced and engage well with healthcare. We're not particularly trying to treat trauma here. That's certainly the job of trauma professionals, but in acknowledging and respecting the trauma that people have lived through, we hope to give them better general practice care. Core principles that we use when we're implementing policy and making decisions from a trauma-informed approach are safety, both of the patients and the staff, trustworthiness, choice, collaboration, empowerment, and also cultural consideration. Of all the specialities in medicine, I think that general practice has the most exposure to both patients as individuals and as part of their communities. So we're well placed to think about how trauma can impact both physical health and mental health, and how it can affect not only the individual involved, but also the people around them. Certainly at our practice, we tend to look after generations of families, and you can see how trauma impacts not just one or two, but even 3 generations. And as a result, we're quite well placed to be able to acknowledge that trauma and make sure that we are providing services that will not make things worse, at least.
Previously, I've worked within mental health, dentistry, and all sorts of fields of healthcare. The approach per se, first off, isn't any different. It's just that the breadth of clientele, breadth of patients that you see is slightly wider, and generally much more on a personalised level. So we generally, on reception, get to know quite a lot of the patients by name, quite a lot of their background, quite a lot of their what's going on in their life and how that affects their health and their need for coming into the practice. So I feel it's a bit more holistic because we take an approach to look at the patient as an individual rather than, in other roles, here's just a broken tooth coming in, or here's just a root canal, or here's just someone with ED or personality disorder or whatever it is that I've come across before. I personally see it as the patient.
So in order to be as collaborative as possible around looking at the mental health services that we currently deliver as a practice in PCN, we invited all of the practice and PCN staff into a room to start thinking about the mental health services that we deliver. And we looked from hour 0, which is when the patient first makes contact with the practice with a mental health need, all the way through to being triaged and then being seen by a clinician or referred into a different process. In order to sort of unpack that process and how different members of staff and patients are affected, we did some persona work where we looked at real life examples of patients who are impacted by trauma and then thought about how we could redesign that service to improve the health of those patients and recognize that trauma. Because obviously it's not practical to be able to hear the voices of all of our 7,300 patients, we asked the PPG to step in as a proxy, as a representation of those voices, to bring forward any ideas they had that could improve the mental health service that we're delivering as it is. As part of that, they looked at the mental health process mapping that we've done as a practice team, and they offered some really valuable insights into how the patient experience element of it could be improved. Off the back of that, we had a conversation with the PPG around the over-medicalisation of patients that have been through trauma. The PPG are now putting together and supporting patient-led condition-specific support groups.
One of the first things that we did to try and foster more trustworthiness between the practice as an entity and the community that we look after was something called an open surgery, which is where we invited all of the patients on our list to the church across the road with the intention that we could talk about why things are the way that they are, the reason behind the decisions that we have made, and give the opportunity for people to ask any questions about the things that we're doing. It was a really positive experience, and I think that by opening ourselves up to that level of scrutiny and giving people the opportunity to come and talk to us and ask questions specifically of me about why things are the way that they are, it has engendered a trust between the staff and the patients that has lasted nearly 2 years later. People still talk about it, people are still asking me questions about it, people are still really positive about that as an experience. Whilst we are sort of understanding that people can have negative experiences with accessing healthcare, and it tends to be that those people who have bad experiences are more likely to publicly comment and voice those opinions. We're trying to encourage both staff and patients to share the positive experiences they've had within the practice. We have a compliments box in reception, and that gets very regularly filled. Both staff and patients will leave compliments for each other, and as a team we will go through those compliments, we'll read out some of the highlights in our practice meetings. Another one of the projects that we're doing to try and think more holistically about the people that we're looking after, especially in the context of the trauma that they've lived through, is to think critically about the reason that people are taking antidepressants and where we can try to actively deprescribe those medicines. We're working as a PCN to try and improve the delivery of mental health care. We're working quite closely with our community partners to try and offer alternative avenues of treatment, for example, talking therapy or group work, engagement in different social activities through the social prescriber. We have increased our GP appointment length, and that's something that I think is becoming a bit more common, to move from 10 to 15 minutes appointments. But the reason that we've done that is to give a greater space for a shared decision to be made between the patient and the clinician. And this will empower patients to be able to look after their own health. It will make them more actively involved in their healthcare, and I'm hopeful that it'll improve outcomes both for the clinical staff, who will give them a bit more time, a bit more relaxed about consultation, as well as the patient experience, where they don't feel quite so rushed into having to talk about all of their problems. They know that they've got a bit of extra time, so that if they need to take a few minutes to explain what's happening or to give a wider context for the reason for presentation, then they're able to do so. We're trying to empower patients to look after their own health as much as possible, both by improving people's health literacy when they're coming into consultation. We'll talk to them about their conditions and how they can help to manage it themselves, but also to actively encourage people to look at their own medical records so they can understand more about the things that we're thinking when we're consulting. We try to be clear in our documentation and quite thoughtful in the way that we write things, so anyone who is reading it, patients specifically, can understand why we've made the decisions that we have, and hopefully will feel more in control of their healthcare as a result.
So since starting as a paramedic practitioner in primary care a year and a half ago, this is quite a new role to be involved in primary care. And I think patients' expectations at the time a year and a half ago were that they were always going to see a doctor for no matter what they came to the practice for. And people were quite confused, I suppose, when they thought that they were going to see a paramedic instead of seeing a doctor. And as part of my role then, I had to explain to the patients what my capabilities were, what my scope of practice was, and build some trust with the patient. And the way that I build that trust is by collaborating with the patient and allowing them to be an important part of the consultation, where they would make decisions and I would make decisions. I often see patients with acute illnesses and acute injuries. Part of my job role is educating people on how to better manage their own health in the community, and that can be done during a consultation, where I can give them advice on how to, if they were to present with a similar illness or injury again, how they can manage their condition at home by either using resources such as the NHS website or potentially seeing a pharmacist through our community pharmacy scheme.
So we are heavy users of the community pharmacy consultation scheme, and we're hoping to encourage and improve people's confidence in using the community pharmacists who have a wealth of experience in managing illness to try and deal with some of those problems that perhaps don't necessarily need to come with us. We also use the social prescriber to try and improve people's social health, and our social prescriber works quite a lot and understands quite a lot about the trauma that people have lived through. And finally, we also make good use of the neighbourhood team, who are a network of professionals who work around the city to try and ensure people's community needs are met. We're fortunate to have a very diverse community of patients, and that includes a number of people who are living with trans identities and other members of the LGBTQ plus groups. We've recognised as a practice that those individuals can and often have experienced quite a lot of healthcare related trauma previously. For example, with coming forwards about their gender identity, or engaging with services regarding sexual health, or even other physical health conditions. Taking time to have sensitive and sometimes a bit longer conversations about gender and what it means, how it impacts their physical and mental health, and then what our role as general practice is in trying to support people through that. We have really good engagement with those individuals, and I like to think that anyone who is a member of our practice community and does have any struggles with their gender identity, that they feel empowered and they feel comfortable with coming forward to talk to us about it, so we can try and help. As well as trying to improve the safety of the patient experience whilst they are engaging with the practice, we also really want to make sure that we're ensuring the safety of the staff. This has led to a more strict application of the patient behaviour protocols. We recognise that people come with a lot of healthcare related trauma, and that can impact on their the way that they engage with healthcare services and the things that they might say and the way that they may behave. But ultimately, our staff have to feel safe coming into work. As a result, we have been much more strict on our the way that we deal with poor patient behaviour. Now, if there's been any report from any member of staff that someone has been rude or been unnecessarily aggressive, then they will be sent a zero tolerance statement and invited in to discuss the incident and give their side of the story to see if we can come to a resolution about what happened, and hopefully help the person to understand that we are only trying to help and we're not really there to be antagonistic. And often actually that process works really well. We have met with a number of people. We've had some really positive outcomes as a result. Occasionally we do get repeat behaviour, and we have a strict protocol on how we escalate that through written warnings. We occasionally will use a behaviour contract to ensure that our expectations of people is clear, and their expectations of us can be clear as well.
We try to be as transparent and accountable and trustworthy as possible with the staff. So we try to have a safe environment where they feel that they can come to any member of the team. Obviously, they report to their line manager, but we foster a culture, hopefully, in which there isn't a hierarchy. So if they feel they need to go and speak to somebody that is a more senior member of staff, they can do that. I think we foster a culture of accountability by creating a workplace that feels safe, where staff, whether clinical or administrative, or whether they're part of our core practice team or their PCN staff, feel that they can come and speak to us about any problems or conflicts or difficult challenges that they may have in the workplace. I hope that we have a culture whereby, regardless of somebody's seniority within the staff team, that questions can be asked. We try and be as transparent as possible. We try and involve as many people as practical within a conversation around processes, policies, just general decision making that we're making as a practice. We have a rigorous induction process. One of the key questions that we ask within that induction process is, what are your expectations of us as employers? And then we try to make sure that we meet those.
So working in a trauma-informed approach allows me to take responsibility for my own practice, and that allows me to feel quite confident in my role, actually, because we work in a very trusted environment. I hope that if I say that I'm able to do something, that I do that. If I'm not able to do it, then I ask another member of staff to help me, or be honest with the patient and just say that I'm not able to do that. That makes that quite a safe environment to work in, where I know that my colleagues will support my decisions. They'll also support me through education. So if something hasn't gone the way that it should have gone, that I'll be supported and educated through that.
On a day-to-day basis, we're much more open communicating. Like I will speak to anyone. I don't mind who I speak to, what level they're at, what I'm talking to them about. And that's how the whole team seems to interact. So we seem to interact in a way that's very open and draws patients into those conversations as well. If you need something, just let us know. We're always here to speak to you, because that's what we're here for. That's, as professionals and as human beings, we need to make that connection.
We're hoping to undertake a number of initiatives. One is to become a veteran-friendly practice. It's well recognised the challenges that people who are veterans face in accessing healthcare services, both physical and mental health care, and we want to make sure that we're acknowledging that and trying to help people with that, rather than either re-traumatizing or causing an unnecessary hindrance. We're also hoping to be more collaborative in our approach to the medical record, and during chronic disease reviews we'll be looking to implement co-creation in the problem list, so people can be more actively involved in helping clinicians, both our practice and other practices, to understand the problems that they face and make sure that that's appropriately coded in the medical record, so that whoever comes to look after this person in the future knows what's important to them, knows what problems are important to them, and in doing so will be able to better support them. We are working with our research colleagues locally to try and be a bit more focused in the types of research that we do, to make it more trauma-informed. We've recently been a part of a study looking at poverty-related mental distress and how we can adapt or change our approach to managing mental health within that particular cohort of people. And that's had some really positive outcomes so far with the clinicians and hopefully with the patients as well. We've been looking to work with our community pharmacy colleagues to co-create almost a trauma register. So we have a good understanding as a practice of the challenges that people have faced, making sure that's acknowledged and documented somewhere in the record so we can avoid re-traumatization both here in the practice and in the pharmacy as well, ensuring people have a consistently positive healthcare experience which will improve their confidence in accessing healthcare services moving forwards. Overall, I think that the trauma-informed approach has been a really positive experience for us as a practice, and certainly be something we'll be looking to take forwards. It's fostered a greater sense of community both between the staff and with the patients. If there's anyone who is interested in the work, I would strongly encourage just doing something as simple as using the principles of trauma-informed care when designing policy. It doesn't have to be so expansive as changing the whole way the surgery is delivering care, or a big change in the consultation model or style, but acknowledging and appreciating trauma for what it is and how it affects people will only serve to improve the relationship between the practice and the patients, and in doing so will make people's experience of care much better and the experience of the staff much better as well.